Hello, I'm Stephen McCurdy, and I welcome you to our conversation on basic study designs. Now, I invite you to think about the various study designs as a set of tools that we use to approach a task at hand. And just as in the wider world, we have to choose a proper tool, be it a hammer or a saw or a spanner, we have to choose the proper tool for a given job. So too in clinical epidemiology, we have to be careful to choose the proper tool or study design for our task at hand, which of course is answering a scientific or research question. So I think it bears some repeating a little bit about some of the principles for selecting a study design. Obviously, the most important question is what is the fundamental question you're trying to answer? But within that, we need to phrase the question itself so that it involves measurable outcomes, measurable exposures, and meets a set of criteria we've run into before, that is the finer criteria. So it must be feasible, interesting, novel, ethical, and relevant. So before we begin thinking then about which particular tool or study design we wish to use to answer the question, we have to first articulate and develop that question, and that's a process that takes some time. Now, once that's done, you've got a set of tools to choose from. These are often broadly classified as descriptive versus analytical studies. In truth, most study designs have some element of have a descriptive aspect to them and an analytical aspect, and I'll clarify exactly what those are as we go along. In MECOR, we tend to focus primarily on those in the red box, that is cross-sectional, case control, and cohort studies, especially cross-sectional and cohort. We will spend some time today on case control, but we tend to use it less frequently in operations research and in MECOR. So under descriptive studies, we generally think of this group of studies, that is a case report, which is a single case, a case series, a collected series of cases, in other words, and a cross-sectional survey, where we're looking at a larger population, some of whom have the disease and some of them do not have the disease. In contrast, a case report and a case series, everyone has the disease that we're concerned with. So descriptive studies have a very important place in clinical epidemiology, in public health, and in medicine. They primarily describe patterns of the outcome of interest, and that's particularly true for cross-sectional studies that we'll talk about in more detail. They answer these three important questions of who, where, and when. Who is affected? Where is it occurring? Where are the hot spots, in other words? And what is the time? What are the time factors there? When did it happen? What is the time course? And the data that we get from these studies can be very useful, even critical, for program planning, for resource allocation, and also for generating hypotheses for further, more definitive research. So let's begin with case reports and case series. Again, a case report is a single case, whereas a series is a collected series of cases of persons, all of whom have the disease or the outcome of interest. In general, they are careful and detailed reports written by clinicians. Usually there are no statistics calculated, but sometimes we can talk a little bit about things such as the percentage breakdown between male and female or the average age. So some statistics may be calculated, but they're generally not a major part of the reports. These case reports and series are important for describing new cases or emerging epidemics. And a little later in our conversation today, we'll see a wonderful example of that having to do with the recent influenza outbreak. These studies tend to require some thought about prospective data collection, but not so much about design. The design is really very simple. For a case report, it's obviously one case, and for a case series, we're merely collecting the cases that we have at hand and putting them together and summarizing them. So here is an excellent example of a very important descriptive case series. So this was published by one of our MECOR colleagues, Dr. Rogelio Perez Padilla from Mexico, and it dealt with the pneumonia and respiratory epidemic from swine origin influenza A in Mexico. The study basically is a collection of 18 patients that were treated in Mexico for this condition. And it was descriptive. It talked about the patients, their age, sex, and so forth, and was hugely valuable for two very important reasons. One, it demonstrated that mortality, death from this influenza, was a real risk for people for whom we would not really expect it. For relatively young, healthy people, there was a risk of mortality, and that was actually very reminiscent of the 1918 flu epidemic. The second very important point from this study was that it showed that healthcare personnel who unfortunately contracted the disease and thus were secondary cases, that they did quite well. So in the jump from the initial person becoming ill to someone who was secondarily infected, in particular the healthcare personnel, there seemed to be an attenuation of the virulence of the virus, which was, of course, very helpful and very much a relief for all of the personnel who had responsibility to take care of these patients. The importance of this, I think, it can be seen in that it was published in the New England Journal of Medicine, which is one of the premier North American medical journals. So please don't underestimate the importance of these kinds of descriptive studies. So let's visit these questions of who, where, and when. Who is getting the disease? So it summarizes the important characteristics, such as age, ethnicity, sex, so the various demographic characteristics, and other characteristics that are known or thought to be related to the disease or outcome. So, for example, with the swine flu, one of the things that would be of interest to know is what kind of animal contact persons had, as well as human contact. We also look at socioeconomic status and HIV status because, certainly those affect rates of tuberculosis, which is a problem that many of us deal with. A cross-sectional survey now differs from the case series in the case report in that it includes people who have and do not have the disease. Thus, it allows a comparison. We can look at the profile of those who have the disease compared to those who don't have the disease. So it summarizes the distribution of this health outcome, whatever the disease is, in a population, and it's at a single point in time. Often we use the term snapshot, such as from a camera. It's just taking a snapshot of the situation at a given point in time. We often stratify it by descriptive factors such as age, sex, and geography. So, for example, we may want to sample or focus our study more in individuals of a given age, either young or old, or a given geographic area than in others. So it can be stratified by these various factors. Here's, again, a further example with TB prevalence, and look at this pattern here. This is very important for program operation. What we're seeing here is the TB prevalence per 100,000 people in Indonesia. And look at the pattern here. With age, we are seeing a clear increase, a stepwise increase in prevalence with age. And we're also seeing really more than a doubling of prevalence in males compared to females. So, and people running programs dealing with tuberculosis in Indonesia, this is very important to know, that the hot spot, so to speak, the place where the disease is really wreaking havoc, causing most problems, is going to be in older individuals and also in males. And so that will have implications for the program design, resource allocation, etc. We next answer the question, where are the disease rates highest and lowest? And with that, where do resources need to be targeted? It can be very helpful to make these geographic comparisons so that we can, again, see where to direct those resources. We might find, for example, that persons living in urban settings compared to rural settings are doing much better or much worse. And this, again, will have obvious implications for program management, and can also help us with thinking about disease etiology to the extent it's not understood. Here's another interesting cross-sectional study that addresses that third question, where. This chart or map shows the percent of all cases of known TB that is multiply drug resistant or rifampicin resistant. So the darker colors imply a greater level of resistance, or a greater fraction of cases or proportion of known cases that are MDR-TB. And we can see from this very obviously that that Russia and the states of the former Soviet Union have a very dark brown color. It's very common among TB cases for the case to involve MDR. Whereas in North America, we can see that it's a very light color. MDR cases correspondingly are a much lower percentage of all TB cases. When does the disease occur? Is the disease frequency different now from in the past? These kinds of secular patterns, a secular pattern is a pattern over time, can be very helpful for understanding, for program management, as well as thinking about etiology and prevention. One of the most obvious secular pattern is seen with cyclical changes through a year. So, for example, influenza has an obvious seasonal pattern that's important to understand. And here we can see that, in the late fall and winter, we can see these bumps through the years of increased incidence of influenza or hospitalizations for influenza.